At the very base of the human torso lies the deep pelvis, a complex anatomical structure designed to manage the final stages of digestion. The terminal segments of this system, the rectum and the anal canal, rely on a highly organized arrangement of specialized tissues to function correctly. Surrounding this canal are the internal and external sphincter muscles. These thick bands of muscle maintain constant tension, providing the critical function of bowel continence, which allows the body to store and release waste precisely when intended. Deep between these two muscular layers, in a narrow gap called the intersphincteric space, sits a row of microscopic anal glands. These glands secrete lubricating fluids that travel down into the anal canal through tiny openings at the dentate line. This precise biological plumbing keeps the canal healthy, but it harbors a microscopic vulnerability: the extremely narrow ducts connecting those deep glands directly to the internal bowel. When one of these narrow ducts becomes obstructed, the lubricating fluid backs up. Bacteria from the bowel quickly multiply in the trapped fluid, sparking an infection. This causes a painful abscess to form and expand, trapped tight within the confined layers of muscle. With nowhere else to drain, the accumulating pus generates immense physical pressure. The fluid is forced to tunnel outward, carving a path of least resistance through the surrounding healthy tissue. Eventually, this advancing tunnel reaches the surface, rupturing through the peri-anal skin to drain. The immediate pressure is gone, but the physical damage remains. The path the pus carved solidifies into a tough, fibrous tract lined with inflamed, unhealthy scar tissue. The result is a permanent structural defect known as a fistula-in-ano. The body has essentially formed an abnormal, unhealing tunnel that directly connects the inside of the bowel to the outside world. A fistula cannot heal on its own. Because the internal opening remains exposed to the bowel, bacteria constantly re-enter and travel downward through the newly formed tract, creating a continuous cycle of chronic infection. To cure the disease, surgeons have to locate and eliminate that internal opening. Since that origin point is hidden deep inside the muscle, they must deduce its precise location based entirely on where the exit wound appears on the outside skin. This diagram illustrates Goodsalls Rule, the diagnostic map surgeons use. The primary axis is the transverse anal line, dividing the area into an anterior, or front, and posterior, or back, half. Goodsalls Rule dictates that if an external opening falls in the anterior half, the hidden fistula tract will run in a straight, direct line from that opening right into the anal canal. If the opening is in the posterior half, the tract follows a curved path to enter at the posterior midline. The exception is an anterior opening over 3 centimeters away. Those long tracts also curve backward. By applying Goodsalls Rule, surgeons are able to take an invisible internal infection and map it as a mathematically predictable geometric path, revealing exactly where they need to operate. This cross-section shows the internal complexity of these tracts, which are classified primarily by how they interact with the sphincter muscles and the anorectal ring, the muscular boundary essential for maintaining bowel control. Low-level fistulas, such as the intersphincteric and superficial types seen at the bottom, cross through the muscle layers below the anorectal ring. High-level fistulas, like the high TransSphinteric type near the top right, pass much deeper into the muscle fibers, opening at or above the anorectal ring. This creates a severe surgical dilemma. The most reliable way to cure the infection is to slice the tunnel wide open. But if a surgeon aggressively cuts open a high-level fistula, they sever the vital anorectal ring, leaving the patient with irreversible bowel incontinence. Before making a single cut, the patient is placed under anesthesia, and the surgeon inserts physical metal probes to gently explore the tract, confirming the exact anatomical path they mapped out externally. For low-level fistulas, the definitive treatment is a fistulotomy. The surgeon simply slices the roof off the tunnel along the probe, converting the enclosed, infected pipe into a shallow, open groove. Because this happens below the anorectal ring, continence is preserved. The surgeon then scrapes away or excises the unhealthy fibrous tissue lining the newly opened tract, which clears the infection and allows fresh, healthy tissue to heal from the bottom up. High-level fistulas require a more calculated approach, utilizing techniques like Gabriel's two-stage operation. Instead of cutting directly through the muscle, the surgeon passes a seton, a heavy silk tie or metal wire, around the deeper part of the tract that contains the vital sphincter fibers. This seton is tied loosely and left in place for weeks. As it is gradually tightened over time, the wire slowly cuts through the muscle layer. Crucially, the slow irritation of the wire stimulates controlled fibrosis, meaning solid scar tissue forms immediately in its wake, holding the muscle firmly together and preventing it from gaping open. Curing a fistula-in-ano requires a mastery of architectural balance. By strategically dismantling the abnormal tunnel while simultaneously forcing the body to reinforce its own vital muscles, modern surgery breaks the chronic cycle of infection, finally allowing the body to close the breach for good. It starts with an escalating pressure. A peri-anal abscess forms under the skin, filling with fluid and swelling against the surrounding tissue to create a sharp, throbbing pain. Resolution usually happens quickly. The abscess either ruptures on its own, or a doctor makes a small incision to drain it. The moment the fluid escapes, the pressure drops, and the relief is immediate. During the weeks that follow, the wound appears to close. It leaves behind only a tiny hole that occasionally drains small amounts of fluid. The pain is gone, leading the patient to assume the ordeal is over. But a few months later, the pressure returns. The exact same abscess swells up, ruptures, and drains all over again. That initial rupture did not clear the infection. Instead, it carved out a permanent, hidden physical defect in the tissue, ensuring the abscess will keep coming back. Looking at this cross-section of the anal canal, we can see exactly what that physical defect is. The initial drainage left behind an unhealed tunnel that connects the inside of the anal canal to the outside skin. This structure is called a fistula-in-ano. Because the internal end of this tunnel remains wide open to the anal canal, bacteria flow into the tract. The body's natural healing response actually complicates the problem. The outer layer of skin tries to heal and closes shut over the external opening. This traps the bacteria inside the tunnel, causing the surrounding tissue to swell and become infected. In a clinical setting, this trapped infection is often characterized by raw, pink granulation tissue pushing out from the mouth of the fistula, while the surrounding skin and tissue become hardened and indurated. This biological trap makes the formation of a new abscess inevitable. The patient is locked into a repeating loop of swelling, rupture, and temporary relief. If left untreated, the continuous pressure of these recurrent infections degrades the local anatomy. When the pressure from the trapped infection cannot vent properly, the pus carves out new pathways. The infection branches off, creating multiple anal fistula with several distinct openings on the skin. If the original infection involved the ischial rectal fossa, the tunnel can spread laterally, wrapping around the posterior side of the anal canal to invade the tissue on both sides. This massive interconnecting tract that loops behind the anus is known as a horseshoe fistula. It leaves the patient with painful, discharging external openings on both the left and right sides. As the physical geography of the infection shifts, surface-level treatments fail to reach the complex network expanding beneath the skin. To break the cycle, the hidden internal tunnel must be completely eliminated, which requires precise diagnostic tools to locate the tract. Clinicians rely on a proctoscopy to investigate the inside of the anal canal, scanning the mucosal wall to find the exact location of the hidden internal opening. They also need to rule out systemic drivers that commonly cause multiple fistulae. In many regions, tuberculosis is a primary suspect, requiring a chest X-ray for confirmation. A tuberculous origin is marked by watery discharge and an irregular opening with an undermined edge. Unlike standard cases, the surrounding skin lacks any hardened induration. The crucial step for a surgical cure is mapping the tunnel's trajectory against the anal rectal ring. This dividing line determines whether the defect is a high-level or low-level fistula. Low-level fistulae open into the anal canal safely below this vital muscular ring. Identifying a low-level fistula provides a clear path to resolution. It means the tunnel can be safely cut open to heal from the inside out, finally breaking the cycle of recurrent abscesses.
Level fistula, the core objective is pretty simple. The tract must be laid completely open. Picture the patient in a lithotomy position. Under anesthesia, the surgeon performs a bidigital examination to locate the cord-like induration, basically the hardened tissue that represents the tract. Next, a probe is inserted. And let me pause here, because this is absolutely crucial. Extreme care has to be taken not to create a false passage with that probe. If you force it and create a false tract, you complicate the whole shebang. Once it's safely navigated, a probe-pointed director goes through the external opening until it pops out the internal opening. Then, the surgeon just opens the tract right on the director with a knife. Got multiple fistulae? You just repeat that for each tract. Finally, they'll either scrape off the unhealthy infected granulation tissue using a Volkmann spoon, or they'll just completely excise the tract along with the surrounding fibrous tissue.
Okay, so the tract is open. What's next? Wound management takes center stage. The newly opened cavity is packed with roller gauze that's been wrung out in a weak antiseptic lotion. And from here, the body actually does the heavy lifting. Healing takes place naturally, with granulation tissue building up right from the depth of the wound to the surface. Now, you might read that some surgeons have tried using split skin grafts from the thigh to speed up healing for the anal wound, but actually, scratch that. Routine practice strongly advises against it. Simple, natural healing by secondary intention is your gold standard for sure.
Section 3. The threat of incontinence, raising the stakes.
Now, what's really interesting about this slide is how suddenly the narrative flips when we move higher up the anal canal. The medical literature gives us a stark, unambiguous warning here. Any attempt to lay open the fistula will cause incontinence. This is literally the ultimate red line in colorectal surgery. When you're dealing with certain high-level fistulas, that standard fistulotomy we just talked about, you have to throw it completely out the window. If a surgeon simply cuts open a high-level tract, they'll slice right through too much of the sphincter muscle, and the patient will permanently lose bowel control. No going back.
Which brings us to Section 4, high-level SupraLevator tracts and treating the source.
So how do we handle these massive risks? Let's examine the first high-level category, the SupraLevator fistula. Now, this one is unique because it's almost never just an isolated, random event. It is almost always secondary to a severe underlying condition. The primary culprits you're looking for here are Crohn's disease, ulcerative colitis, a carcinoma, or sometimes even a foreign body.
Because this fistula sits so incredibly high above the levator ani muscle, and because of that severe threat of incontinence we just established, the treatment protocol is actually going to sound totally counterintuitive. The mandate? Treat the primary condition, manage the Crohn's, address the carcinoma, and literally ignore the fistula entirely. Seriously, any surgical attempt to lay this specific fistula open is strictly off the table. The anatomical consequences of cutting that high are just too devastating. Moving right along to Section 5. TransSphinteric and Gabriel's operation, navigating secondary tracts. When we get into TransSphinteric fistulas, surgical ingenuity really has to kick in. Picture a primary tract that crosses right through the external sphincter, often with branching secondary extensions. You'll almost always find a low fistula alongside a high perforating secondary tract. And guys, this is a massive trap for a surgeon. If they aren't incredibly precise, that probe-pointed director can slip into the high secondary tract. If they push too hard, it can blast right through into the rectum above the anorectal ring, disastrously creating an artificial high fistula. So the workaround is a dual approach. The lower tract is laid open as usual, but the upper secondary tract, it is purely scraped wide with a Volkmann spoon so it can just heal by itself alongside the open low fistula.
And this brilliantly illustrates how surgeons have to adapt when a standard dual approach just isn't enough. Enter Gabriel's two-stage operation. This is an absolutely ingenious workaround designed to fully eradicate the deeper tract while completely preserving the sphincter complex.
Gabriel's operation is all about playing the long game with the body's own biology. Here's how it works. In stage 1, the surgeon does a standard fistulotomy below, but then they pass a loose seton, like a heavy black silk thread or a rubber band, right around the deeper part of the tract that contains intact sphincter muscle. They tie it loosely outside. For the next 2 weeks, that seton just sits there in situ. Why? To intentionally trigger fibrosis, or dense scar tissue, right next to the muscle. Then, stage 2 happens around 6 weeks later. The surgeon goes back in and excises the remaining tract, actually cutting the sphincter fibers that were tied within the seton. You're probably thinking, wait, won't that cause incontinence? No, because that fibrosis we stimulated in stage 1 acts like an anchor. It literally prevents those freshly cut muscle fibers from snapping back and retracting. It's a total masterpiece of surgical staging.
Oh, and there's a wild variation to Gabriel's method too. Instead of using a heavy silk seitan and doing a second surgery, the surgeon might pass a stainless steel wire around the deep tract. Over the next 2 weeks, instead of a second excision, the knot on that wire is gradually tightened during routine dressing changes. Basically, over time, the wire slowly physically cuts right through the sphincteric muscle. Sounds terrifying, right? But the magic is exactly the same. The sphincter won't gape because fibrosis has already formed right behind the wire. The body heals it exactly as it's being cut. Incredible stuff.
Now for our last stop, Section 6, Inner Sphincter Banius and the Wanley Operation, Managing the Horseshoe Fistula.
Let's see how all this logic applies to our final high-level category, the high intersphincteric fistula, specifically when it branches out into a deep posterior U-shape known as a horseshoe fistula. Now, trying a radical unroofing or a massive fistulotomy on a horseshoe tract is a recipe for disaster. It would destroy the pelvic floor. Instead, surgeons use the Wanley operation. Here, they skip the radical unroofing entirely. First, they do a posterior midline internal sphincterotomy to enter the deep postanal space. Then, they only lay open the very deepest part of the fistula tract to drain the infection while meticulously excising the remaining lateral branches. It's a highly targeted, conservative procedure that eradicates the complex, branching sepsis while keeping continence perfectly intact.
So, as we step back and look at all these techniques, from the delicate probing of a low fistulotomy to the intentional scarring of a stage seitan procedure, all the way to the precise excisions of the Wanley operation, we find ourselves right back at our core dilemma. How do we ultimately balance the absolute eradication of a fistula tract with the critical preservation of a patient's continence? Well, it's a true testament to medical innovation that the answer isn't always to just cut deeper. Sometimes it's to pause, stimulate fibrosis, and let the body